Hi, I'm David Christensen, a fellow in respirology at the University of Toronto, and this is the first in a series of 6 10-minute videos on the basics of pulmonary function testing. I have no relevant conflicts to disclose. Let's look at the objectives for the 6 videos. The first is to discuss the indications for and the proper performance of pulmonary function tests. We'll then define common terminology used in PFTs, and to understand the concept of compliance and how it influences PFT results. We then want you to be able to recognize and describe the pathophysiologic basis and the differential diagnosis of the PFT patterns of obstruction and of restriction. And lastly, we'll describe diffusing capacity measurement and interpretation. Let's get started with the first video, Introduction to Pulmonary Function Tests. The objectives of this lecture are to list 5 indications for PFTs, to describe 4 patient factors that influence predicted PFT values, and to discuss the methods for distinguishing normal from abnormal PFTs. Let's discuss the clinical indications for PFTs. Firstly, patients may present with symptoms such as cough or shortness of breath that are referable to the respiratory system, and we want to further investigate their lung function. Secondly, PFTs are required for the diagnosis of certain diseases such as asthma or COPD. In other cases, serial PFTs are useful to follow the progression of disease over time, such as with idiopathic pulmonary fibrosis. In other cases, PFTs can be used to determine a patient's suitability for lung resection surgery. Lastly, in workers exposed to occupational noxious dusts or fumes, PFTs can be used to screen for preclinical disease. So before we go on, let's review some basic terminology used in PFTs. The first is volumes. A volume is an amount of gas that can be either held within the lungs or inhaled or exhaled. This is obviously measured in liters, and a common example would be the tidal volume, which is the volume of air that's breathed in and out with every relaxed, normal breath. Generally, it's activation of the respiratory muscles that lead to changes in lung volume, with the one exception being exhalation during tidal breathing, which is purely passive. The next term to understand is flow. A flow is a volume of gas that is inhaled or exhaled in a given unit time. As such, it is measured in liters per second, and an example would be the peak expiratory flow rate, which is the flow rate of air in a maximal exhalation. Flows depend on several factors, including the patient's effort, the strength of their respiratory muscles, the physical characteristics of their chest wall, lung parenchyma, and airways, as we'll see. Now that we have a rough idea of what we'll be measuring, let's discuss how normal values for PFTs are derived. They are derived from large cohorts of healthy, non-smoking individuals. The largest such cohort is the Global Lung Initiative, which was conducted in 2012, which looked at spirometry, a type of pulmonary function test, in over 74,000 patients in 26 countries over a broad range of ages. They also divided their subjects into 4 racial categories, which are important, as we'll see. This set of standard reference equations is recommended for in-office spirometry in Canada. An older but commonly used dataset is the National Health and Nutrition Examination Survey, which you may come across. Let's look at the effect of some common parameters on predicted lung function. Here we have age plotted on the x-axis with lung function plotted on the y-axis. A commonly used index of lung function is the FEV1. What we see in a patient's childhood and adolescence is a rapid increase in their lung volumes due to growth. This peaks at around age 20, and lung volumes gradually decline over time as the patient ages. The situation for males is very similar to that of females, although lung function tends to peak a little bit later at around age 20 to 24 and actually declines slightly more rapidly over time. The reason this normal decline with aging is important is that a male aged 80 may have only half the lung function of a male aged 20, but still be considered entirely normal. Thus, it's crucial to know the patient's age in order to predict what their lung function should be. Let's look now at the effect of height and weight. As we've seen, from about age 20 onwards, lung function declines gradually with age. As your height increases, your starting value for lung function increases, and the decline is similar as you age. This is because the size of the torso, and therefore the lungs, is directly proportional to the patient's height. The situation with weight is a little more complicated. Obesity generally does not depress airflows unless patients are significantly obese with a BMI over 35 to 40. Obesity does tend to depress certain lung volumes, as we'll see. But by far the most important contributor of these two variables to predicted pulmonary function is height. Let's look now at the effect of race. When we look at large population samples, it turns out that Northeast Asians have about a 3% smaller lung volumes compared to Caucasians, Southeast Asians about 10% smaller, and African Americans about 15% smaller. Note that the exact differences vary depending on the pulmonary function parameter we're talking about. The reason this is important is that different pulmonary function test labs account for racial differences in different ways. The preferred method is to use race-specific reference equations, where a subject is compared to individuals of the same race. Oftentimes labs will use an adjustment factor based on the percentages shown in the table here, and other labs won't correct at all. And this is important to know because you may falsely identify someone who's African American as having low lung function. Now that we've discussed what contributes to the predicted pulmonary function, we need to decide what is normal versus abnormal. Let's say we look at lung function over time in a set of individuals and took a cross-section of individuals aged 40. What we would see is their FEV1s would be normally distributed around a mean predicted value. The way we decide what's abnormal is generally to use the 5th percentile predicted or lower and to consider that part of the population abnormal. Similarly, above the 95th percentile predicted, it's also considered to be above normal, although this is less clinically relevant. In summary, the lower limit of normal is preferred, but in labs that do not report a lower limit of normal, often the percent predicted of the mean between less than 80% and greater than 120% is considered abnormal. So let's look at what you actually get back when you get a PFT report. The top section is the demographics, which includes the date, patient's name, indications for performing the test, as well as any respiratory medications and smoking status. The next section is spirometry, which is the simplest and most useful part of the pulmonary function test. This can also be performed in any family physician's office. Spirometry also comes with a diagram called a flow volume loop, which we'll discuss later. Next is a measurement of lung volumes, followed by a measurement of diffusing capacity. And last but not least, the technologist's comments, which should be read first and are critical to evaluating the integrity of the pulmonary function test report. The next 4 videos are devoted to describing how these data are generated and how they should be interpreted. One last point that deserves mention is quality control. Pulmonary function testing is critically dependent on the technologist's attention to detail. They must be able to instruct the patient appropriately, and the patient must be able to comprehend and follow the advice of the technologist. There must be a rigorous standardization of both the procedures and the equipment to ensure repeatability over time. And any recent smoking or inhaled medications done by the patient should be recorded, as they can influence test results. Lastly, certain patients are susceptible to infections transmitted by PFT equipment, and appropriate precautions must be in place. Let's review the objectives of this video. Number 1, to list 5 indications for PFTs. Number 2, to describe 4 patient factors that influence predicted PFT values. And number 3, to discuss methods for distinguishing normal from abnormal PFTs.